Any questions to start out with? I had a host of questions right before class, which I guess I should have had you guys do it in class. That would have been probably better for everyone else, but it's okay. Any questions at all? Everyone feel pretty comfortable going into this Kahoot? Nope. That's, well, you got a day and a half to study for Pharm, so good luck. This is why we say study every single day for every subject. You guys don't need to sleep. Okay, let's get started. Do questions along the way if we need to. All right, which antidote drug combination is correct? Oh, you can't see it? I don't know how to make that any bigger. Does it not show up on the app?
Oh, there we go.
No? Stinks. This is also a test of your visual acuity. Well, okay, shh. So who can't read that from the back? Several individuals. I'm going to see. Hold on. Let me try something. Let me. No, that's rude. Let's see. Anyone know what a 4x3 setting is off the top of their head? It's not 640. Maybe this one will work. Holy, that's different. That might work. Oh, this might get cute. Oh no, I'm trying to.
Okay, April can't fix this one. For everyone who keeps telling me.
Is that better? Oh, weird. Dr. Wood fixed it. I can fix some tech things. Yeah, this is just a resolution issue, but that's okay. All right, so let's talk about it now that people can see. So that's a freebie for people in the front row, those that have very good vision. All right, so looking at the antidote drug combinations, idurucizumab or Praxpine, what is that an antidote for? Pradaxa, otherwise known as dabigatran, right? So kind of a fun name, right? So that's one of our direct thrombin inhibitors. That's one of those oral new anticoagulants, right? So that one's important because if you have a patient who's coming in bleeding and you need to reverse that very quickly, this might be the only drug you have available. Because we mentioned things like fresh frozen plasma doesn't really help it out because as you add in new plasma that has factor 2, guess what? It's inactivated by the dabigatran already there, that Pradaxa. So that monoclonal antibody is very potent to do that, but again, you need to think it's very expensive. There's anaphylaxis risk you have to worry about, and then like who's going to actually carry that? Because they're newer drugs. I don't know a lot of hospitals that have that on hand in order to treat one of these reversals. That would be kind of one of those things where it's kind of like a roulette of like, okay, where am I going to send my mom who's bleeding, have a head bleed to because she fell over while on this drug? Where is she going to go to? Do they have that drug? I don't know. And that could have a direct effect on whether someone lives or dies or has pretty significant morbidity. So again, new oral anticoagulant drugs are nice because what's the benefit of using those drugs? No INR monitoring, right? So warfarin was the old king of anticoagulation, oral anticoagulation, but because we lost that, now we don't have as much monitoring, which is great for a lot of patients, but you lose a lot of that easy reversibility. That's an issue. Anyway, is there a reversal agent for aspirin? Not really, right? You can't really do anything with that necessarily, which is, it's okay because, aspirin bleeding usually is not going to be nearly as severe as you see with like a heparin or a warfarin or something like that. There's a lot of bruising, a little epistaxis, things like that, but you don't really see the same kind of bleeding like you would unless it's, in combination with other drugs potentially. So how about phytonadione or vitamin K? What is that a reversal agent for? No other antidote drug combination, you should know vitamin K is going to help to reverse the effects of warfarin. How long does that take? Yeah. It can take a couple of days before you really see the full effect of that vitamin K. And why is that? Yep, so I'm giving new substrate for the liver to use to make clotting factors, but it doesn't do anything with the fact that warfarin's already depleted our clotting factors to begin with. So in addition to vitamin K, what else could I give? Yeah, so FFP is the other thing. That's the immediate fix. That's what's going to fix your patient immediately. Vitamin K is going to help them on kind of the more longer tail of that to help make sure their INR is going to go down. I didn't go over the guidelines specifically on how to address super therapeutic INRs, right? So there's subtherapeutic, which is not going to be too low, but there's super therapeutic, which we're talking about here. You know, they're points where you're going to go ahead and decide to use just vitamin K, or you may use the combination. So if it's kind of a minor increase in your INR, sometimes you can just get away with changing the dose, right? Just go down 10% or so. Other cases where you're having much higher INR, so again, what's a therapeutic INR? Yeah, so usually 2 to 3 for like AFib. When do you shoot a little higher? Mechanical valves, or if there someone had some kind of you know, genetic predisposition to being really hypercoagulable, they might shoot for a little higher too. But mechanical valves is the one really big one. So 2 to 3 is typically what we're going to shoot for. So say they come in like, you know, say 5. You know, again, this is a ratio, so they're 5 times, the blood's 5 times as thin as you would see with a normal healthy patient. So in those cases, you may do vitamin K by itself. But, you know, if they're having any kind of major serious bleed, like give the FFP. That's the thing that's going to fix them immediately. So that's the thing to consider with that. How do we reverse enoxaparin? So I didn't really mention it in class. It's kind of one of those things where it's kind of more of a minor point. You can get some reversal of protamine, but it's not 100%. So very rarely would we ever use protamine with an enoxaparin, say overdose, or if someone had, you know, poor renal function, they're holding on to too much. Very rarely would we do that. We normally just give it the tincture of time. Just let it metabolize on its own and go from there. But then we see that protamine sulfate is going to be that reversal agent for heparin. That does work very well. Again, not super common that we need to use it because heparin has a fairly short half-life.
So just to clarify, so you're saying if it's over, the INR is over 4 or 5, then you do vitamin K, and if it's anything more than that, then you do the fresh frozen plasma?
I'm not going to test you on that specifically, but there are some guidelines out there. Like if you look at the CHEST guidelines for CHEST is a journal, and they have anticoagulation guidelines for a lot of this stuff. They will have recommendations, and so usually if it's like, usually don't jump to FFP unless they're actually having like any evidence of actual bleeding, like so GI bleed, head bleed, anything like that. That's usually when you're going to jump to that immediately. When you get to lower, so say it's like, you know, say 4 to 5, you know, it actually goes up pretty high before they actually recommend giving FFP kind of automatically, but usually you can go with either oral or like IV vitamin K. It just depends on how high their INR is. A lot of times you just like can hold a dose or two, and then that will kind of get them back down to where they should be. A lot of cases there. But again, with warfarin, it takes time for all this stuff to kind of re-equilibrate, because it takes time for that those factors to start to be generated or to be inhibited, as the case may be, right? What would like a subtherapeutic? If I said like, oh, this patient has a subtherapeutic INR, what would you think that is? What number would come to mind? Yeah, 1, right? Can you drop below 1? No, not really. I mean, the test is really you're looking at their patient's PT versus kind of the standard kind of normal patient, and so based on that, you really never see like an INR less than 1. I don't know if there's any weird case. Maybe your test is reading weird or something, but 1 is really the bottom of that. Just like a GCS. Like, you guys know what GCS is? Yeah, Glasgow Coma Scale basically is a way to kind of to see how alert or kind of with it your patient is. You know, comatose patient. You know, it's always funny when like new medical providers are coming out and they're like, they had a GCS of 0. It's one of those things where like you can't have a GCS of 0. The minimum you can have is 3. So sometimes it's good to know the minimum scores you can have on things. Otherwise, you sound kind of goofy. Okay, question. Another question.
What if they have like an iron overload?
So an iron overload, what would that do for us? Because iron goes into the production of hemoglobin, we know, but that doesn't really affect your clotting factors necessarily. And in fact, in some cases, we can actually see that iron overdoses. One of the things you can actually see is that bleeding, because iron is very corrosive to the GI tract. So I've had like GI bleeds that can happen secondary to iron overdoses and things like that. But that shouldn't really have much of an effect here from this standpoint, right? So again, know your antidotes, know what drugs are going to go with. That will probably come up again somewhere, at least in this, if not the test, right? All right. The Tizinator out front. All right, which of the following would be a reasonable treatment for atrial fibrillation? Generally tell how confident you guys are about which side talk's going on. And what's a reasonable treatment for AFib? All right, good. So what would nitroglycerin do for us? Vasodilates. If anything, what would that cause? So decreased blood pressure. What would the heart do as a response to that? Yeah, so sometimes you actually see reflex tachycardias do that. So that would not help alleviate or AFib, right? How about lidocaine? Why wouldn't that be a good option? So it's not super good for treating atrial arrhythmias. If you go back and look at the 1B antiarrhythmics, remember lidocaine falls in that category, really saving those for ventricular arrhythmias. Because remember, like with AFib, that tissue may or may not be healthy, right? So some people just have that kind of predisposition for it. Some of it may be due to ischemia, but more than likely, you're going to see a lot of ischemia occur in what part of the heart? The ventricles, right? Because those are the kind of the most meaty part of it. That's where you're going to have the most oxygen consumption. So those normally take a hit. And we mentioned that the 1Bs typically work better in ischemic tissue, right? So you're going to see that those are going to be much more effective for ventricular arrhythmias. We don't use them a ton for atrial necessarily. Okay, so that would not be a good option. And how does lidocaine work? Being a 1B antiarrhythmic. Yep, sodium channel blocker, right? So just like it works as a local anesthetic, it can do that on the nerves to deaden those action potentials. It can do the same thing in the heart. Now, adenosine, what do we use that for? Yeah, so SVT is the main thing. So if you had, those really rocking heart rates, that's going to 180, 190, and you need to slow that down immediately to fix that issue, adenosine can be very good for that, but it doesn't really treat AFib from that standpoint, right? Because again, it's not really a sustained action. We really just want to like stop the heart for a second, give it a chance to reset itself. It's like turning your computer off and back on again. But in cases you're kind of killing your patient for just a second and then bringing them back, not really. Usually they're kind of with it the whole time. But yes, sir.
You said the lidocaine works better for ventricular?
Mm-hmm.
Okay.
Yep. So if we can't use that, then we would use diltiazem, which is what type of drug? Non-dihydropyridine calcium channel blocker, right? And that works by doing what? Slowing the AV node, SA node, right? So we're slowing the amount of calcium that's coming in. We saw that calcium is really important for causing that initial depolarization for those slow response cells, those pacemaker cells. So that would actually work very well for this. Because again, the big issue we're worrying about is having too much conduction from the atria. Because the atria, they don't need to be that efficient, right? They can sit there and quiver and it's not a big deal, because the big thing we're worried about is ventricular function to get that blood out and pumping to the body. Because again, what's the biggest driver of blood flow from the atria to the ventricles? Gravity, right? So most of that flow just happens by gravity alone. So we don't need the atria working super well in the first. We'd like them to, but they don't have to. It's not necessary. The ventricles, though, we worry about having too fast of a conduction from the atria to the ventricles, and so if that occurs, then you may see that decompensation there. So we can slow that down with our non-dihydropyridine calcium channel blockers. Similarly, what else could I have picked in this case? Beta blocker would work just as well. So metoprolol, esmolol, any of those would have been just fine, right? Inderol, which is propranolol for anyone who's curious. Sorry, it might be too soon. Sorry. Okay. So any questions on that one? Yes, ma'am.
Is there a heart rate at which you would use adenosine and not use adenosine?
It's one of those things where if you read the EKG and you're getting that interpretation of like SVT versus just like AFib, and again, I'm no expert at reading EKG, so someone like Professor Hilton or Professor Quinones could probably give you a little bit better insight into that. But basically, you're reading the rhythm, you're kind of assessing whether it's an SVT or like an AFib, and then you can make your decision based on that. So usually, when it comes like to at least my practice in the ER, they would say, "Hey, you got this patient with SVT." I say, "Great, I'm going to get the adenosine." They've already made the diagnosis, and I'm coming on the drugs and getting ready to that to go. Remember, what's the big issue with giving adenosine? Very short half-life, which means what? You got to give it as quickly as you can, right? So you need to have that kind of that contraption where you have the three-way stopcock. One end's on the patient, one end's on the saline flush, and the other end's on the drug, and you go push, push, get that drug in there as quickly as you can to make sure it actually makes it to the heart before being degraded, essentially. Right? Good. Any other questions on that? Make sense? Okay. All right. Which anticoagulant works with antithrombin 3 to inactivate factors 2, 10, 9, 11, and 12? Don't get intimidated by the factors. What's the important part here? All right, so the correct answer is heparin. So key points to note here. So what are we asking? So we're working, what drugs are working with antithrombin 3, which includes what? Includes heparin. What else? Low molecular weight heparins, and then also, in addition, Erixtra, right? So fondaparinux. All those work with antithrombin 3 to make it work better. The question is, what factors are they inactivating, right? So we said, which ones are kind of the most specific one? Only works on factor 10. Fondaparinux, yeah. So fondaparinux only works on factor 10, right? So it's very, very short. It's just that pentasaccharide, right? It's only 5, sugars long essentially, and it's very specific for factor 10. Low molecular weight heparins, on the other hand, are mainly affecting what? Mostly 10, predominantly 10, and then a little bit 2, right? So 10 and 2 are kind of the big ones. So think about driving, 10 and 2. Those are the big ones you want to affect us from a coagulation standpoint. Heparin being a much longer molecule, right? Being the unfractionated heparin, tends to be less specific and it's going to work on several different clotting factors. So you see why this one's affecting, say, 5 different ones primarily, rather than, obviously 10 and 2 are still the most important ones, but it still can affect other ones like, 9, 10, 9, 11, and 12, I should say. And then warfarin's affecting mainly what? Yeah, 2, 7, 9, and 10, but just think about those vitamin K dependent clotting factors. I'm not going to get so granular to be like, is this affect 2, 7, 9, and 10, or 3, 5, 8, and 13? Like that's kind of outside of our scope. We don't really care about that so much, but it's important to know it's a vitamin K antagonist. It's going to affect clotting factors that are dependent on vitamin K to be made, right? And remember, like it's also effective in affecting protein CNS, and we said protein CNS do what? They're anticoagulants, right? So that's why we initially see when you start a patient on warfarin, you have to worry about that bridging therapy, right? Because initially it can cause a hypercoagulability. So you need to cover that by giving what drug? Something like heparin or low molecular weight heparin. Any of those would be fine to give in those cases. We had to bridge over, and so that way you kind of keep the patient anticoagulated while CNS are being degraded, but then the other ones are going to be affected as well. And that's when you have the true anticoagulation effect there, right? Good. Any questions on that? Okay. Yes, sir. I've never done those both at the same time. So again, you mentioned APTT is used to monitor what? Heparin, right? So, but antifactor 10A is primarily used for what? Low molecular weight, and you could also use it for Erixtra as well, that fondaparinux. So you could use those for either. I've never done both at the same time. I would probably think that there's not a perfect correlation that's been defined to know to say like, okay, well, if I have an anti-10A that comes back, it might not be in the same range as I would see with like an enoxaparin would cause. So, and then when you have like an enoxaparin on board, you don't really see much of an effect on APTT because it really doesn't affect factor 2 quite nearly as much. It's just more inconsistent. So I would say there's probably a little bit of activity, but probably not as much as you would see with either one essentially. That makes sense. So you wouldn't order it. You basically say if a patient's on heparin, you just order APTT. If they're on enoxaparin, you'd order antifactor 10A, right? And in general, do you need to monitor enoxaparin or other low molecular weight heparins? Not usually, right? So this is one of those cases where like we do it very frequently in kids because they tend to be more sensitive to this stuff. Again, their kinetics are a little different. We tend to do this in very overweight patients because again, their kinetics change as they get this kind of increased adipose tissue as opposed to their lean body mass. So there's cases where we do it, but it's not super common. We can usually just do a weight-based dosing, give it to them Q12, 1 milligram per kilogram, and they're set to go, right? Heparin though, you have to monitor for when you're doing it therapeutically. If you're just doing like Q8 hour sub-Q dosing for prevention of clots, you don't really have to monitor that. However, if you're doing like a therapeutic infusion, you have to monitor APTT because again, that can shift pretty dramatically based on small changes in dose.
So for Pradaxa, which is a direct Pharm inhibitor, does that not have any association with antithrombin?
Yeah, so that has no association with antithrombin 3. It's a direct to a antagonist, and then so it's similar more to like your other direct thrombin antagonists. So if you think like your lepirudin and bivalirudin and those drugs, like it's kind of more similar to that than you would see with like heparin specifically. And that's another good thing because when you're thinking about monitoring parameters, APTT doesn't really tell you that, right? So it doesn't really show any kind of consistent results to say whether this patient's therapeutic or not. Some people have looked at like thrombin time, which I guess abbreviated as TT, but I've not seen anything really definitive saying that yes, we should monitor this pretty routinely. So I think it's one of those things where it's one of those things where we don't know that there's a change in TT that occurs, but we don't know the range that would be considered therapeutic versus sub or super therapeutic. All right. Next up, Which medication provides mortality benefit in CHF patients? If you get this wrong, you're in trouble. It's the best response I can hope for. Just increased exhalation.
Firstline treatment for congestive heart failure.
Interesting, interesting. Okay, so mortality benefit. So spironolactone is the correct answer, right? So we said that in what type of CHF patients, though, specifically? Yeah, stage 3 and 4 heart failure patients. Those are the ones that have been shown in studies to have mortality benefit, right? So again, when would that drug be contraindicated? So if they're having, so serum creatinine is too high, right? Because it shows they're not going to be clearing certain electrolytes and things very well. And what's the other thing? Yeah, potassium is too high. Because again, what is a spironolactone? How does it work? Aldosterone antagonist, and that does what to potassium? Should increase, yeah. So you're going to hold on to more potassium. So again, keep in mind those contraindications. That's very important to know, like, who's going to be a candidate for spironolactone. Again, this is more of kind of a once you get your ACE inhibitors on board and your beta blockers and your blah blah blah. This is usually kind of one of the later drugs to add on. But acetazolamide is what type of drug? Perfect. Carbonic anhydrase inhibitor. It's kind of a wimpy diuretic. Not going to be good for CHF, so we don't care about that one. How about Lasix? Does that provide any mortality benefits? No, it is good for getting off fluid, and it can help with symptomatic control, but actually has not been shown to have any benefit on mortality. So that would be incorrect. Good for symptoms, not for mortality. It's important to keep those distinctions in mind when you're kind of coming up with drug therapy for patients. How about HCTZ? It can help with their hypertension, right? So, but it doesn't actually improve mortality benefits for CHF patients specifically, right? So they may be on it for other reasons. They may be on this plus Lasix, especially if they have that loop resistance. You guys remember we talked about that? Where sometimes if a patient becomes more resistant to a loop diuretic because the distal convoluted tubule is kind of picking up the slack, you can add on a thiazide diuretic, and that will help to increase diuresis. So neither of those provide mortality benefits, but your aldosterone antagonist. Alternatively, what could I put on here? Eplerenone or the Inspra is the brand name for that one. So that one also could have worked here. Again, main differences between those two. The gynecomastia is going to be worse with spironolactone, right? Because again, it's going to be kind of an androgen receptor, kind of partial agonist. So it's kind of the ones, the big side effects you worry about. Okay. Jigglypuff out in front. Which of the following inhibit DNA synthesis by acting like a false nucleotide? And I got to deal with almost all of these last Friday because I usually work Fridays in the pharmacy on the evening because that's usually when management's gone and you can kind of just chill out and just kind of deal with the patients that are there. But no one had done all the chemo for the infusion center for the next day, so I got to deal with all of these fun drugs. You know, I love chemo. All right, pretty good. Yeah, so the correct answer here would be cytarabine or Ara-C. So how does docetaxel work? What category does that fit into? Goes into the taxanes, right? So remember, it comes from the U tree. How does that work? It affects microtubules. Good. How does it affect the microtubules? Yeah, I remember increase that stabilization, as they can't really break themselves down at all and kind of depolymerize. So that's the taxanes. They're going to work on that. So they would not be a false nucleotide. They affect mitosis, but they don't actually affect DNA synthesis at all. How about etoposide? Hmm? Hmm? They have a very minimal effect on microtubules. The more primary thing with those in particular is the topoisomerase inhibition. So those affect topoisomerase to prevent those strain breaks, or if the strains have been broken, they prevent the enzyme from reattaching them. So again, DNA damage, but again, not affecting actual incorporation of some of these false nucleotides. How about methotrexate? Folic acid antagonist. So would that category or be fitting into this category? It's an anti-metabolite. They just prevent production of new nucleotides, right? So they're not going to necessarily get incorporated at all. However, cytarabine is the one that gets, it looks just like, you guys remember what it looks like? Starts with the C. Yeah, it looks like cytidine. It's going to get phosphorylated and get incorporated into the DNA, and it's kind of that strain terminator, right? Because again, DNA polymerase can't add on anything to the end of that, and so it's done at that point, right? So too much DNA damage can trigger apoptosis, and there you go. Okay, make sense? So you can go back to your mechanisms, know how these drugs are going to be working. They fit into their different categories. Because I'm not going to ask you, like, which one to use for leukemia. So you got to kind of fall back on things like what are the side effects, what are the potential interactions we may have talked about, mechanisms, all that kind of stuff. So kind of the bread and butter kind of things about these drugs, because you may not ever work in HEMONC, unless it's really kind of your passion. But you may be dealing with these patients who are coming in and they have a history of being on these drugs, and so it's important to kind of understand at least the basics about them, so you can at least look it up and figure out what you need to. Okay. Which of the following agents is cell cycle specific? I know what you guys are all going to review tonight. All right, pretty even split here. So again, no drugs go into which categories based on their mechanism. Carmustine, cyclophosphamide, and temozolomide all fall into the same category. They fall into the alkylators, right? How do they work? The alkylate, yes, that is true. Where did they alkylate? Yes, they're going to be binding up to usually guanosine in the guanine in the DNA. They're going to cause interstrand connections that can occur. It's going to change the conformation there, prevent things like DNA polymerase from working on it, causing DNA damage, right? Those are cell cycle non-specific because they can affect the DNA at any point, right? That's not only during synthesis, it's not only during mitosis. Those tend to be cell cycle inspecific, and so you see a lot more kind of severe side effects because a lot more cells, cells that may not be actively turning over, like you see in the GI tract or the hair, things like that, that can be affected by this. So you can see things like ototoxicity. You can see more things like nephrotoxicity, even though those cells are not really rapidly turning over like you would see like in leukemias and things like that. However, vinblastine works via which mechanism? Goes in those vinca alkaloids. They're also affecting those microtubules, right? So these are going to be on the opposite side of the taxanes. These are going to be working on actual synthesis of microtubules. So you prevent that, meaning they're going to be working specifically in which phase? In mitosis, yeah. So those are going to be the primary place where you see the vincas actually working there. Good. All right. A patient taking sildenafil or Viagra for erectile dysfunction is at risk for severe hypotension if he mixes it with? Huh? I'm sorry? That should be pretty familiar. Oh, that question was? Oh, so everyone should get this one right. Nice. It just goes to show you how important of a counseling point this is for your patients, right? And imagine if you have a patient who's seeing multiple providers and you didn't know that one of them put him on nitrous, his cardiologist put him on nitroglycerin, but you didn't have a full med rec, and then you say, hey, I'm having issues with the wife, and then you prescribe an erectile dysfunction pill. Like, you can see how these errors can occur here. So that's why counseling is so important. Good. So Viagra working as a phosphodiesterase inhibitor, causing smooth muscle relaxation. Again, that's how we'll talk about that when we get to the urology section next semester. But the main primary one is nitroglycerin interacts with that. Why is that? Nitroglycerin donates nitric oxide, right? So it's donating to that whole pathway, the same pathway where you're generating cyclic GMP. So phosphodiesterase inhibitors prevent breakdown of cyclic GMP. Now nitroglycerin is producing more cyclic GMP. You see how it's very synergistic. So you can see big drops in blood pressure, syncope associated with that, hypotension, so all of that you want to be careful of. Usually you won't see like just that with like a beta blocker or really any of these other drugs. But the primary thing is the nitrates. That's the big thing to worry about. And again, that's a really tough thing when you have, like, say your EMS is responding to a call for chest pain, and then they need to ask those questions, right? Is the guy they start having angina due to the fact that he was mid-coitus, and then now he's you want to give him nitroglycerin, but you didn't realize that he's on an erectile dysfunction pill. Like that's a clinical concern, right? These are things you have to think about. It's not that funny.
It was great.
Okay. There's no other nice way to put that, I should say. Okay. For arrhythmias, beta blockers are considered. Think about the mechanism. Think about how they are affecting the heart. Good, perfect, right. So why is it not rhythm control? Because it's not, yeah, right. Because it's not really fixing the arrhythmia necessarily. It's just slowing down that conduction from the atria to the ventricles, right? So you're slowing down the actual conduction. It's a negative inotrope there. So by doing that, you're getting more rate control than you are necessarily rhythm control. There's no cardioversion with a beta blocker necessarily. It's more of that rate control, right? All right, the original Warcraft pits humans versus what creatures? Oh, see, the nerds are. I think I made these no points, but.
There's an RTS series called Warcraft.
Who knows this one? Interesting. No, it was humans versus orcs. I'm sorry, is the correct answer there. But I'm glad the majority of you, at least half of you, were aware of that. So good job. Yes.
It's about the other question.
Oh, I was about to say, what question do you have about this? Let's not explore the depths to which I know about Warcraft, okay? Let's just leave that off the table. Yes.
Beta blockers, you said negative inotrope. Isn't it chronotrope?
Yes, I should have said chronotropes. Negative chronotrope, right? So slow down heart rate. There's even negative dromotrope. You guys know what dromotrope is? It's actually the speed of conduction itself, right? So it's not inotrope is mainly like the heart rate. Dromotrope is the negative the speed of conduction. Is that right?
I think it's inotrope.
So it's both, right? Yeah. So the inotrope is just the speed of the actual heart rate. The dromotropy is the actual speed of that conduction. They're very similar, so we don't really talk about it that often. You can double check me on that if I'm wrong. Anywho, that may be a correction for later. I was trying to act all smart, and then you guys might prove me wrong. Okay, moving on. Which of the following is a reason for a patient's INR to be supertherapeutic while on warfarin? It needs to be a valid concern for it to be supertherapeutic. Usually inotropy is just actually the contraction of the squeeze of it. Yeah, they're both. That's why I mentioned it previously, so you guys got to figure that out, right? It's either subtherapeutic or you're super therapeutic, so which one? Okay. So the reasons why super therapeutic means INR would be too high, right? So the INR is too high, so they come in and the INR comes back and it's like 5 or 6 or something like that, right? You're shooting for 2 or 3 and it comes back much higher than that. So reason for that, why would it not be an all spinach diet? That would lower INR, right? Because you're providing extra vitamin K, and again, don't just say K, because again, that can be confusing if you mean vitamin K or potassium, right? So you'll be careful with that. So if I said like an all banana diet, that probably wouldn't really affect. That would have been a pretty good detractor on a test. Might have to think about that for next year. But that wouldn't be right though, because again, getting too much vitamin K increases clotting factor production, and that could lead INR to drop. Yeah, it's going to go back down, right? So again, and it's not that your patient can't have any spinach at all. They just need to be consistent, so that way the dose is affecting that amount of vitamin K they're intaking, you know, on an average week. How about a patient was starting on a 2C9 inducer? Right, that would do what to metabolism of warfarin? Yes, it would increase the metabolism of warfarin, which means it's working less effectively, which means your clotting factors are still being produced, so INR will be lower, right? So you get to think about these kind of like, okay, this one's down, so it's going to go up here and down here and up here. So you keep those kind of relationships in mind when you're thinking about inhibitors and inducers, right? Okay, patient accidentally misses doses due to memory impairment. That would also lead to be lower, right? Because they're not taking their doses as they should, so that'd be an issue. And how about this one? Patient was placed on Bactrim for a UTI. Why is that an issue? Yeah, so there's a little bit of 2C9 inhibition. What's the other factor to it? Less vitamin K. Why? Yeah, so you're affecting GI flora, and that's the other big thing, because a lot of vitamin K we know is getting generated by the bacteria that we are then absorbing. If you get rid of that gut flora, then you can accidentally see that come back very much. You know, getting rid of that flora, INR is going to climb because of that, because they're just taking less vitamin K. Again, keep these relationships in mind, how these are working, right? The most difficult patient I ever had to dose on warfarin was one thing we'll learn when we get to the HIV section next semester is that HIV drugs are notorious for causing CYP inhibition and CYP induction. So mainly CYP inhibition is one of the big things you'll see. We actually give combinations of drugs, so that way you actually boost your levels of the antivirals in order to get more therapeutic levels. And I had this patient who had Hep C, he had HIV, and AFib. And so it was this like really old guy. And again, this is in Putnam County. So again, collard greens are like a staple of the diet. So it was just like trying to get this guy therapeutic on his INR was like the most difficult thing. I was there for 2 months and did not get him therapeutic until the very end of the actual rotation. It was just like, yes, I finally got him. But man, it was just a drug interaction nightmare from that standpoint. So you gotta be really careful with a lot of these patients, looking at their comorbidities and other medications they're on. Anyway, okay, what is the name of this character? Another, just for funsies. Don't give away the answer. Hold on, shh. Shh. Yeah, so if they had to be on a CYP2C9 inducer, which again, clinically there's not like a ton of those, but if they had to be on a 2C9 inducer, you could basically give them an increased dose, right? So this is why they, again, usually what you find with warfarin when you're having to come back in for their PTINRs, you have to check them pretty frequently for the first, if you have any kind of dose changes or if you have any kind of changes in diet or medications, things like that, they'll come in more frequently, so that way you can monitor their INR, make sure they don't go through the roof, but keep in mind it takes days for it to really kick in. And then as they get stable, then you can kind of back out their appointments. So they can do like maybe once a week for 2 weeks, and then you go out to a month, and then maybe they come in every 3 months or so, right? So that's usually the kind of general course for a lot of that stuff. But yes, that was Yoshi. Anyone know the full name for Yoshi? T. Yoshisaurus munchakoopas. I looked that up yesterday. I cannot lie about that. Huh? I don't want to talk about it. Anyway. Okay, which antidote drug combination is correct? We had that question already, didn't we? We'll have it again with chemo. All right. Sweet. So looking at our antidotes and the drugs, and for chemo is just as important as it is for heme drugs. So dexrazoxane, does anyone know what that works with? Yeah, it's with our anthracyclines. So think doxorubicin, daunorubicin, those drugs that are producing those free radicals, right? Remember those reactive oxygen species that can cause the cardiac damage? This is actual chelator, and iron's really important for generation of free radicals and those oxygen species. So by giving dexrazoxane, you can bind up some of the iron, primarily in the myocardium, and that will help to limit that damage. So you can actually give larger lifetime doses for these drugs when you give these, or if you have evidence of say myocardial damage being done, you're starting to see some of these myopathies, you may be able to get away with giving this drug if they still had to receive the chemotherapy. So there's just some limited use cases for that, but that would be the antidote for that one. Is there an antidote for vincristine? No, there's nothing really to go with that one. So again, your vinca alkaloids don't really have any antidotes. How about acrolein and cyclophosphamide? Does this make sense? What is acrolein? Yeah, that's actually the byproduct of cyclophosphamide that causes a hemorrhagic cystitis. So we actually give an antidote to prevent that, and that antidote is Mesna. Yeah, so we actually give Mesna in order to counteract that acrolein. It'll bind it up and keep your bladder working just like it should, right? So prevent that hemorrhagic cystitis. Is there an antidote for cisplatin? Lots of hydration, really. That's not really the only thing you can do for that drug, because again, cisplatin is known for causing what sort of toxicity? Remember Chemo Man? Remember his ears were little C's? I used to think cisplatin, and the other big one was the kidneys as well. So the kidneys also got hit with that one. Again, hydration, vigorous hydration is really the only thing you can do for those patients. It's not really a true antidote, so to speak. But we know that methotrexate works as a folic acid antagonist, and so in order to counteract that, we give thalinic acid, right? So it's the activated form. So you kind of bypass methotrexate, and you'll do these leucovorin rescues for a patient who gets a big dose of methotrexate. You really knock down their whole immune system and all of that, and then you will give them this leucovorin rescue in order to try to replenish some of those healthy cells as much as you can in order to get their system kind of back up to speed. So that way you can give them another dose of methotrexate later, essentially. Okay. All right. First-line agent for angina in a patient with asthma, diabetes, and prior MI. This would be for control and prevention of anginal symptoms. Our Enderall friend came back. Interesting, got a wide spread here. Okay, so why is propranolol not correct? Non-cardioselective. They have asthma. You don't want to do that, right? So we don't want to do that one. How about lisinopril? It would be indicated for this patient due to the fact that he has diabetes, right? And it's also probably just good for heart health. He already has CHD, obviously, by signs of angina and prior MI. He should probably be on an ACE inhibitor regardless. But does that do anything for anginal symptoms? No, doesn't do anything. How about aspirin? Also, he probably needs to be on aspirin. Not going to help us with our anginal symptoms. It can hopefully prevent further blockage from occurring or any kind of platelet aggregation, but that's not specifically for that. Metoprolol, though, which is a cardioselective beta blocker. So, right, beta 1 selective, so it's going to spare those beta 2 receptors. That would be a preferred agent for this type of patient. Make sense? All right. Which of the following is not a common side effect of methotrexate? Not a common side effect. All right, yeah, so this is basically just, basic side effects of, these chemotherapy drugs. So diarrhea, absolutely. Why does it cause diarrhea? Yeah, GI cells are have a rapid turnover. Those are getting hit as well as the the white blood cells and hair and everything else like that. So that's going to take a hit. Leukopenia, absolutely. We know these are immunosuppressive. We use methotrexate all the time for leukemias. How about renal dysfunction though? Is that associated with methotrexate? That's one of those ones we have to give pretty vigorous hydration. Also, we give sodium bicarb because we worry about it precipitating out in the kidneys and causing interstitial damage. When we get to talk about urology and nephrology, we'll talk more about drug-induced kidney injury, but this is one of the big ones you have to watch out for. So we give a lot of sodium bicarb to try to alkalize the urine, raise that pH up, and prevent that from precipitating out. So that's one to be concerned with. It's kind of more unique for methotrexate than you see with a lot of the other chemo drugs. But hirsutism, not usually a common thing. If anything, alopecia you'd expect, right? All right. Why are some chemo regimens considered to be count dependent? Not like Count Dracula, but blood count dependent. Right, this one's just kind of a gimme, just for reiterate a point here. We don't need sufficient cancer cells, and in fact, we want as few cancer cells as possible, right? That's why we give chemotherapy to try to wipe out as many of them as we can. We do not test for neuro impairment by having the patient count. That was just kind of a goofy one. And then also hospitals making a profit. We don't care about that so much. We want our patients to be cancer-free, right? Screw the profits. Capitalism bad. But no, we need a patient's immune system to recover, right? So usually we're looking at absolute neutrophil count is one of the big things we're looking at. We're looking at platelets to make sure they have recovered. Because again, if we are worried about our patients succumbing to secondary infections, we worry about them bleeding, all kinds of things like that. So, giving the chemotherapy is just one piece of the pie. You also have to look at these kind of adjuvant therapies where we can give like colony stimulating factors to try to recover their immune system. Sometimes we have to give extra platelets potentially, but they need to achieve a certain level before we can give them chemo again to kind of knock them back down. So again, we'll have patients have to be delayed week to week because they just aren't recovering that well on their own in a lot of cases. That's one of kind of the challenges. We have to delay chemo even though you know those cancer cells are constantly dividing. You know they're coming back, but you can't do anything because otherwise the patient might succumb to your treatment, right? Okay. How excited are you to be done with Pharm after Friday? I feel for you. Did you see all the EpiBio stuff has now been posted? We're gonna have one more in class session, but then the videos are posted. It's probably a lot shorter because I'm just talking to myself in my office for the most part, so it tends to be a little shorter than if we had all the in-class sessions. All right, so please watch those videos. It's imperative for your testing success. Okay, anyway. Those of you said not as excited for Pharm 2, you guys are liars. I don't appreciate being pandered to, okay? All right. Which chemo agent could lead to osteoporosis in female patients with breast cancer? Kind of goes back to those hormonal agents that we were talking about. This is one where the brand name might actually help you. All right. So why is it not raloxifene? What type of drug is that? It's a SERM. It's a selective estrogen receptor modulator. What the heck does that mean? It can be used potentially for prevention. Why is that though? Why can't I use it when someone has breast cancer, which is ostensibly estrogen positive, estrogen sensitive? Right, so it depends on the tissue you're dealing with, right? So not all estrogen receptors are created equal. In the breast tissue, you may find that drug can act as an antagonist, whereas in the uterine tissue, it'll act as an agonist, and the bones will act as an agonist. So it's important to keep those in mind, because when we talk about kind of women's health later on in the second semester, we'll talk about things like, okay, does your patient have a hysterectomy or not? That can depend, or that can decide what type of drugs you're going to use for them based on things like estrogen content of drugs, or if you have to oppose estrogen action. Regardless, the raloxifene is nice because it's a selective estrogen receptor modulator, which means it'll act as an antagonist in the breast tissue, an agonist in the bone, and can actually help to prevent osteoporosis, if anything. So that's kind of one of the nice things with that one. Doxorubicin, would that really affect anything with the hormones? Not really, right? It's one of those anthracyclines. It's going to be the things that like intercalate into the DNA, right, to cause that conformational change. Affects topoisomerase to some degree. It's not going to be really affecting that. Flutamide, anyone know what that one is? That's actually an anti-androgen, so you really wouldn't worry about that one. So specifically, it's more for like prostate cancer and male patients. How about exemestane? What is this one? This is one of the brand name can help you. Yeah, it's an aromatase inhibitor, but it's irreversible. That's really the big thing. So again, if you had a patient who is maybe on raloxifene, but they were unresponsive to that, and you need to get rid of even more estrogen, this is something where you can use this irreversible, basically aromatase inhibitor. That way you kind of just wipe out all estrogen, right? So again, think about the side effects that come about from that. You're basically putting your patient in menopause if they weren't already there from that standpoint. Okay. All right. Which monitoring parameter drug combination is correct? Let's go back to heme, I believe. Kind of talked about this already, so let's see if you guys remember. Probably had it on a test today, if I had to guess. No traps. Perfect. Almost perfect, actually. So close. So dabigatran, how do we monitor for that? You don't, right? So we can't really monitor for that. So that's no good. PT-INR and warfarin, you guys should know that. Like peanut butter and jelly, PT-INR and warfarin, that should go together right in your mind, right? APTT, what's that used for? Heparin, right? Just heparin, right? APTT, heparin, that's what you should think of. Enoxaparin we would use. It's a low molecular weight heparin we would use. Anti-10A. Routinely, you don't have to monitor for it. It's routinely nothing, but if you need to monitor for it, anti-10A would be the way you kind of monitor for efficacy, right? And then thrombin-time and Orextra, that would not be the case. What could I use for Orextra? Still anti-10A. You can still use that for that one because, again, it's only really affecting factor 10, very similar to the low molecular weight heparin, just even more specific for factor 10. Thrombin-time we don't use routinely for monitoring for medication-induced anticoagulation. All right. Which patient would be contraindicated from receiving alteplase or TPA? Let's say they have an MI, the cath lab was closed down for whatever reason, we didn't have access. We had to bust that clot in the ER. You may say fly him out to somewhere else so he can't get to a cath lab. It's probably one decent option, but if our attending was really gung-ho about giving this drug. All right, so there's two right answers on this one. So again, contraindications are super, super important whenever you're considering giving TPA because it's probably one of the more deadly drugs you can give, right? You have to be cautious because, yeah, I want to, patient has an MI and I want to go ahead and bust their clot, right, in the coronary vessels. But where else might I bust clots? everywhere, right? So you worry about hemorrhage, you worry about brain hemorrhage. I remember for whatever reason this really stuck with me. I was doing on rotations when I was in school, and we were doing this like kind of lunch and learn kind of thing where and this is like really old attending doc. He must have been like 9,000, I think. But he was talking about when they originally did these trials, and this is more related back to TPA and use for ischemic stroke when they were using it for those. And they were talking about the trials they did where they were basically they had no idea what the actual dose was, and so they're doing these large trials where you got this dose, you got a little bit higher dose, and they're randomizing patients these trials, and they're like, how many deaths were associated with that, right? Ethically, you were still okay doing it because that was kind of the best treatment for it. But to find just the perfect dose, like, this is kind of people where you kind of equated them being kind of heroes because nowadays we know very well what type of dose to use for those patients, et cetera. So, always think about the human component. For whatever reason, that sticks out to me. But here, we will see that if you go back and look at your contraindications, at least be familiar with them. This is a big checklist you're going to go down every time you consider using these drugs for the purposes of getting rid of one of these clots or for fibrinolysis. And so pregnant patients would definitely be contraindicated, right? Because that can have a negative effect on the fetus, so you would not do it there. Blood pressure, this is actually a really important one because if the diastolic goes too high, namely over 100, you can try to give an antihypertensive to get them back down, but usually if they fail 2 rounds of that, then they're contraindicated from receiving it. So again, in a lot of cases, they're probably pretty hypertensive to begin with, kind of what beget a lot of their issues. How about this GI bleed? Why do you think this is not contraindicated? Yeah, it's a little bit more recent bleed. So 3 months is usually the cutoff for a lot of those kind of more recent bleeds. That would not be one. How about shellfish allergy? Huh? Yeah, that would not be one that's not made from shellfish sources. It's against a recombinant sort of TPA to make it look just like a human TPA molecule would. Okay, question?
Yeah. Okay. So like, if there was like a question and it asked like which is the most correct, or I guess that's what, like the most contraindicated stroke patients or pregnancy if those were both options.
It was already told that it wasn't going to be a give back.
Well, yeah, I know. I'm just trying to.
Oh, I see what's going on here.
She said.
So.
Dr. O classified pregnancy as a relative contraindication, not an absolute contraindication in thrombolytics.
That's tough. I would definitely defer if I was in that situation. If I had a patient who were dealing with an ER who needed a thrombolytic and they were pregnant, that is something I'd be like, let's get OB here, let's get hematology here, let's talk to all the experts before we decide to give this, because obviously time is tissue. That's one of those things where like, let's see how relative it is to these people, because again, it's very much a risk-benefit analysis you have to consider with that one. So I would think it's more of a closer to absolute contraindication, but there may be cases where you may consider doing it. But again, that's one of those things where you want to fall back and make sure you're definitely referencing back to the experts for that one. Yes. What type of stroke, though, is the question, right? Yeah, so again, a hemorrhagic stroke. So if they had a hemorrhagic stroke, then obviously they're at risk for having another one, right? So that's one of the big things to worry about. Because, yeah, you fix a patient's heart issue, but now all of a sudden they have a head issue, and that could be also debilitating and or fatal, so it's no good. Okay, any other questions on that? Trying to pit professors against one another, for shame. Okay, which of the following medications have mortality benefits in CHF patients? I saw this one also. Don't doubt yourself. Go with what you know. If you don't know anything, then that's a little late for that. They're all correct. Remember, you can sub in an ARB for an ACE inhibitor. That's no problem. They probably have a little bit less data out there than for mortality benefits with the ACE inhibitors. But again, the main thing is you want to inhibit that renin-angiotensin system. How you do it doesn't really matter. So any of these would potentially work. What would lead you to decide one versus another? Cough could be a big thing that make you want to use what? An ARB, a sartan, right? What else? Well, why not kidney problems? They're both therapeutically equal, right? So either one could cause potential an acute kidney issue, but again, both of them are going to be nephroprotective for your patients. So it can be good for them. Think about patients' insurance. Think about cost. What's going to be what can they get on the $4 list at Walmart, because that may be their whole drug budget for the month, right? So you got to think about things like that, because if they can't afford it, guess what? They're not going to take it, right? Compliance is going to be nothing. Okay. Which antiarrhythmic association is correct? So class to drug, which one fits? I'm sorry? I did like 50% cardio, 25% roughly heme, roughly 25% oncology, roughly speaking. I try to make it pretty even with the amount of time we spend on the lectures and all that. So.
Are the two cardio components roughly equal, or?
Roughly, I think. I didn't go through and double check that, but it should, roughly speaking. Yeah, no. Okay. So why is defetilide not a class 2? What is it? The class 3. Defetilide is a class 3 antiarrhythmic. It is a potassium channel blocker, right? That's the one that kind of fits in the same category as what other drug? What's the kind of the primary class 3 you think of? Amiodarone, absolutely. So again, you got to think about QT prolongation by causing that. Think about really with this one, you got to be really careful with the electrolytes. You got to make sure you're monitoring their potassium, their magnesium. If those go out of whack, then you have your patients who have develop another arrhythmia because of that. Okay. How about magnesium? What does that fall into? It's like a miscellaneous. So it doesn't really fit into a category. So that would be incorrect. How about nicardipine? It's a calcium channel blocker, but it's not a non-dihydropyridine. So you need to have either diltiazem or verapamil. Those are your class 4 antiarrhythmics. Nicardipine is a dihydropyridine that would only work on the vasculature, not going to affect the heart necessarily, right? Or directly, I should say. But lidocaine is a class 1B, so that one would be correct. What's your class 1A antiarrhythmics? It's PDQ, so it's quinidine, procainamide, disopyramide. Those are 3. How about your class C or 1C? Propafenone and flecainide is the other one. So propafenone and flecainide, I think about those 2 primarily. Good. And then class 2 are beta blockers. Yep. Good. How about Sodalol? What does that fit into? That's actually class 3. Even though it's a beta blocker, it has potassium channel blocking abilities. So we don't use it as like typical like antihypertensive or for MI, but we use it as an antiarrhythmic typically. So that's kind of one of the one-offs. Okay. Which medication is best suited to treat an acute episode of angina? Not an obtuse case of it, but an acute. Sometimes I am obtuse, but. But hopefully you'll get this one right if you take the right angle on it. Geometry joke. All right, yes. So for an acute treatment of their anginal symptoms, the first line drug you should always go with nitroglycerin, absolutely. So certainly you could think about using like verapamil or metoprolol if they're like really tachycardic and you're thinking that really has a lot to do with their they're kind of an acute symptoms, but that's not the first thing you go with. Nitroglycerin is always the thing to go with acutely. Verapamil, metoprolol, they're going to be better for kind of prevention of symptoms, kind of increasing their exercise tolerance, better for kind of chronic maintenance of therapy rather than for an acute episode. Amlodipine obviously is better as an adjunctive agent, would not be used by itself, especially not for an acute episode. All right, good. And then last question for arrhythmias, flecainide or Tambicor is considered. So this is what type of Antiarrhythmic, what class?
1C.
Yep, 1C. Yes, this would be rhythm control, right? So think about, what do we say is good for rate control? Beta blockers and non-dihydropyridine calcium channel blockers. So like really class 2 and 4 are the main things we're going to use for rate control. But with things like 1C antiarrhythmics, 1A, those are going to be able to convert those rhythms into a normal rhythm potentially, as arrhythmias into a normal rhythm. This is actually one of the things we used to use flecainide. There's a whole thing they did called pill in a pocket, where the patient felt like they had a case of AFib coming on. They would take this kind of on an as-needed basis, and actually saw there's increased mortality associated with that. So a lot of things are moving towards more using rate control than necessarily rhythm control. Having being an AFib is not necessarily that big of a predicament as long as you're anticoagulated appropriately. But if you can control that rate to make sure the ventricles are going to be kind of stay in line, then you're good to go for the most part. But this would be a case of rhythm control, right? Make sense? Okay. So that's it. Our winners are Chicken Little. Chicken Little. Nice. Good job. How about silver here? Team 76%. Seems a little low. Maybe team 80%? 85%? And then Gabba Dabba Doo. Very nice. Good job. Good job. Congratulations. Your free answer is C. There you go. All right. Any other questions I can answer before I let you guys go? Thank you for a wonderful semester. I appreciate any constructive feedback. No clapping is necessary. No. You're almost done. After Friday, you'll be at least done with one of the major hurdles of your PA career. And then you got to do it one more time. And we also increased the lecture hours. And there's 4 tests instead of 3. So you guys will be fine, though. You're mostly halfway done. Okay, no questions? All right, email me if you can. Earlier is better. Otherwise, Friday morning is usually not a good time to answer questions. So, all right, I'll see you guys next time.